So we're going to give you 60 seconds each to run through yourself, who you are, a little bit about your company and opportunity. And again, maybe your superpower if you want to do that.
I'm the founder CEO of Bayesian Health. A little bit about my background. I worked in AI for a little over 20 years in research at Hopkins as a professor across AI and health, advancing the fundamental technology, translation, and also serve as a SME on the AI regulatory side to several of the federal agencies, co-founded Coalition of Health AI, which works with 1,000 organizations, including the federal agencies, several of the federal agencies around AI oversight. Bayesian was a company we spun out of Hopkins with 5 years of IP, and it's essentially a multimodal clinical AI platform. So a lot of AI examples you're hearing are all across imaging. As soon as you move out of imaging to start to look at all the other kinds of data that exist, the labs, vitals, unstructured notes, not just a single modality like just text or just imaging, but the disparate, like thousands of modes of data that exist. AI for multimodal data is just sort of a whole lot harder and a whole lot more complicated. A lot of my research focused on advancing AI in those use cases. And if you can do that, you can solve really high value, hard problems that you couldn't do before. As an example, in 22, we published these trials, 3 manuscripts that came out on the cover of Nature Medicine in sepsis, which is the leading cause of death in hospitals. Open problem in the field. So many people have tried. So many people have attempted but haven't made it very far. We showed effectively 5.7, like 10x better performance than anything else that exists today using our platform. And effectively what we showed in these manuscripts was 5.7-hour earlier detection than best physicians at Hopkins across 750,000 patients, a massive trial. We did this across academic and community sites. So effectively, over 2.5 years. So pretty massive trial. So one, the ability to detect. The second set of things we showed was 90% provider adoption, because it's one thing to detect. The second is this provider is going to adopt. And so in these trials, again, very 2.5 years sustained adoption by 4,400 clinicians using the platform. And then, of course, if you have earlier detection and adoption, then you're going to see outcomes. And we showed nearly 20% reductions in mortality. These were one of the earliest and biggest and one-of-a-kind results in terms of the adoption data, but also the mortality data. And from there, we've gone now and we're implemented at places like Northwell and Cleveland, and are partnering with systems like Mayo and Memorial Care and Theta Care and LifeBridge, and just as and are again replicating. So, for instance, at Cleveland, within a month, we went from implementing to 92% physician adoption, and are scaling enterprise-wide across all U.S. hospitals. I talked a lot about sepsis, but really, Bayesian's platform tackles. There are about 20 to 30 such odd conditions where effectively the ability to detect early, facilitate diagnosis, treat and manage patients gets to better clinical outcome and financial outcome, like deterioration, pressure ulcers. So we're working on a range of conditions with our health system partners.
Summarize the key message that you would tell in this very short period of time you have of your clinical and economic value propositions, and make sure you tell us if you're reimbursed or if you're just, an enterprise sale that's going to just fit into the overall economics, and explain that business model. So it's really ultimately business model that we're kind of going after here, as well as the benefits.
I'll start with a simple example. So I said it's a multimodal clinical AI platform with multiple solutions on it. Sepsis as our leading beachhead product. A patient, when they come in with sepsis, let's say it's missed, the person ends up being hypotensive, they end up having multiple complications, they end up in the ICU. A hospital is getting paid a certain amount on a DRG. So if they end up being there for like 20 days versus a 5-day, that excess money is just out of their pocket. If they're using a lot of ICU days, that's just out of pocket. So the first level financially, the impact is from detecting this patient early, they can treat this patient in a timely fashion, save on secondary complications leading to ICU utilization, longer length of stay. So suddenly someone who's like a 20 per day or 10-day or 12-day or 15-day could end up becoming 6 days, 5 days. So a big savings on length of stay and the excess cost. So that's number one. The second is, if a patient comes in as present on admission, you're able to document them as present on admission. On many DRGs, that's a much more complex patient. So you're able to get 30, 40, 60, 70, 80 in some cases % higher reimbursement. And then the third is many of the conditions we tackle include, and many of the conditions we are tackling today have the same phenotype: length of stay, revenue from better documentation. And then the third is penalties. There are areas where because these are critical areas, there's reporting to CMS around performance. And so as a result, there's awareness around penalties attached to it, and they're looking to, not be spending money or losing money because of those penalties. So that's on the financial side. On the clinical side, often health systems have like teams invested in this area, right? There are whole quality teams that are focused on improving these because they're high value, important areas to tackle. So one, it improves patient outcomes, it improves on key metrics like length of stay mortality that many contracts are tied to on whether you're a fee-for-service system or a VBC system. And so, those clinical outcomes are obviously improving. It has also reputational benefit. The third, and very interestingly from a frontline workflow perspective, is they have a lot of tooling today that they hate. It's like alarms and alerts that create a lot of BPAs and noise. For instance, at Cleveland, as an example, we showed 10,000, like a 10x reduction in alert volume, 10x. So they went from 10,000 alerts to 900 passive flags, but we were catching 40% more cases. So from a provider burnout perspective, we dramatically simplify the workflow. We're reducing, an existing tools they have that are clunky. And then from an IT perspective, because it's a platform where we're not just sort of putting one point solution, but like multiple multimodal clinical AI solution. Today, a lot of those are the ones we've built, but now, we have some news coming where basically other systems are now implementing and deploying that through us. What makes us something they want to partner with is our adoption, our provider adoption. The fact that we can drive provider adoption is where, people have struggled with AI solutions. And so our ability to reliably and consistently drive provider adoption is what gives them comfort that we can go after many areas together that are high value, high stakes.